Thank you for joining us. This year, I'm talking about aortic valve repair. This is something that's not particularly known among the cardiology community, how often we can repair the aortic valve with really good results. And so here at the Cleveland Clinic, we're up to 4,680 aortic valve repairs now as the end of last year. And the results are really looking good. The best results are actually with the reimplantation operation, with a 97% freedom from reoperation at 10 years. That's equivalent to a mitral valve repair. And so I urge you to consider even more having your patients with aortic valve regurgitation, whether bicuspid or trileaflet valves, to have them seen for potential repairs. So with that, I'm going to cover quite a lot of ground around the whole issue of repair. One thing to remember about COVID is that COVID has been obviously a big significant factor in deaths. And here's the numbers I took from the Wall Street Journal of deaths in 2020 versus 2018 heart disease and cancer. And as you see, it's the third most common cause of death. What is also of concern is that cardiovascular disease as of October last year started increasing. And for those of us who deal obviously in the area of cardiovascular disease, we know a lot of patients have been avoiding having their examinations or having their chest pain checked out. Let's talk about aortic valve regurgitation and repair of valves. And here's a patient with a regurgitant valve, and we then will go through the steps. For a three-leaflet valve, we do the reimplantation operation. We mobilize the aortic valve, put pledgets in the left ventricular outflow tract, and put that valve inside a tube graft and then sew that in position and hook up the coronary arteries. In 2019, we did 1,371 aorta cases, and valve-preserving operations, particularly the reimplantation operation, has become a much more common part of our practice. This is a 2018 data, and 2020 we did 1,381 aorta operations despite COVID, and 780 on the ascending arch, including reimplantations, and there were 138 reimplantations that went down to 112 in 2020 for a total of reimplantations of 1,113, which is by far the biggest experience in the world on reimplantation operations. And here's the data for reimplantations over time, and notice they went down slightly in 2020. So as I mentioned, we've done 4,680 aortic valve repairs as of the end of last year, and of those 1,430 were bicuspid valves or unicuspid valves, and there's our outcomes for the various operations we do. Notice that for isolated aortic valves, our aortic valve data for both replacement and repairs is 0.3% risk of death, and bicuspid valves 0.3% also for some 3,000 patients. Another point is that the risk of death for us at the Cleveland Clinic from 2005 onwards approximately, the risk of death for a reoperative aortic valve is very similar to that of primary isolated aortic valve, although the long-term survival is slightly different, but this is out to 20 years as you see there. So when should you operate on enlarged aortas? Many years ago, I looked at Marfan's patients and found 15% dissected at a size less than 5 centimeters. And we then looked at both Marfan's and bicuspid valves and came up with this formula, which is the cross-sectional area greater than 10, indexed to the patient's height as a ratio, as an indication for surgery. So what that means is a shorter person with a smaller aorta, we operate earlier, and say 4.7 centimeters gives you a ratio of 10 in somebody who's 5'6". So here's a relationship with height and dissection. So shorter persons dissect at a smaller size, and if you use the ratio, that then adjusts for it. Our cardiologist took this one step further, looking at CAT scans and the cross-sectional area and survival over time. And if patients had a ratio greater than 10 in purple here, the survival was much worse over time if they did not have surgery. And here is another way of looking at that, and for the aortic root, this was even worse than for the ascending aorta. Tara Karamalou looked at our pediatric population of Marfan patients, 81 patients, and also found that if you look at the ratio over time and the kids growing, that's a better way to look, and a more stable relationship in red here over time. And here you'll see the variations over time, but the cross-sectional area helps in managing patients and seeing when they deviate from the regular growth curve. In this particular study, obviously a lot more kids, the cutoff was lower for operating on patients. Let me mention a bit about the guidelines that I was involved in drawing up. And in the guidelines, we said a ratio of 10 for Marfans as a cutoff for surgery, obviously addressing the issue of short, particularly women with Marfans, and a cutoff of 5 centimeters for surgery. On Turners, we also recommended using the ratio because they're obviously short. Loeys-Dietz, we recommended 4.2 centimeters, and I'll come back to that. And for Marfan patients who are contemplating pregnancy, we came and recommended 4 centimeters. So we did a study on following up our bicuspid valves. We had 5,600 odd who had CAT scans and MRIs, and then we chose the ones with a aorta above 4.7 centimeters and bicuspid valves. And of those who had aortic surgery immediately, there were 800, and then there was a surveillance group. In the patients who had surgery immediately, the risk of death was 0.25%. In the surveillance patients, we followed those up over time. Well, what happened? Well, we found that the dissection risk increased for the aortic root at about 5 centimeters, and then for the ascending aorta, about 5.2, 0.5, 0.3 centimeters, the risk of dissection increased. When we used the ratio and looked at that, we found that the ratio was the best predictor of when to time surgery for patients with bicuspid valves and enlarged aortas. The other thing is we looked at what happened over time, and as you will see here, even patients at 4.7 centimeters starting at the time of follow-up, by 10 years, about 50% of those had undergone surgery because of the aortic enlargement and valvular heart disease. So why repair? Well, part of the reason is that the freedom from both death and complications related to mechanical valves at 10 years is about 50%. And so obviously, if you can repair the valve, that's a better scenario. What about pericardial valves versus allograft? Well, as I think everybody knows, the younger the person is, the greater the failure of those valves over time. And this is a curve actually I use quite a lot in discussing this with patients as far as 12-year durability. Powder blue here is rate of repairs, and obviously the younger the patient, we repair the valves. How do we do it? This is particularly important for those of you who do imaging, looking at MRIs, CAT scans, and especially echoes. These are the things we assess when we are planning to do a repair. So commissures, leaflets, annulus, sinuses, and the sinotubular junction. All of those need to work together to have a successful aortic valve repair. All right, what do we do for bicuspid valves? Well, the key to many of those repairs is the Cabral suture shown there in Plagiates. But what we found also very helpful is this sort of figure of 8 on the commissures and hitching those at a higher level apart from plicating the leaflets. And here's the illustration of that suspensory suture that raises the height of the approximation area of bicuspid valves so you get better apposition of the leaflets. So there's the Cabral sutures and plication, and here's the figure of 8 suture. On the outside there you can see that that's hitched up that valve. And there's a running suture at the leaflet edge that we sometimes use to try and reduce the risk of prolapse over time. Here's what we do with a bicuspid valve and the remodeling operation. So there you see the repair, and then we bevel the tube graft to accommodate those commissures when we do the repair. Here's another patient with that reefing suture on the edge of the leaflets, and we use a hay gauze to make sure that we don't cause stenosis of the valve. And there's a nice symmetrical bicuspid valve after repair. And then we do the rest of the ascending aorta repair in this particular patient. So what about that patient? Look at the apposition of the leaflets there. I like to be at about 3 to 5 millimeters of apposition from the point of view of durability of these repairs. And there you see no regurgitation from the leaflets in that particular patient. And there's the 3D image. On our data are based on 728 bicuspid aortic valve repairs. The more recently operated patients appear to have better durability. Obviously, we don't have 15-year durability, but it's looking pretty good with the newer techniques. Let me just mention one operation we also do, particularly in the elderly, which is a tailoring operation. So we put in those figure of eights and Cabral sutures if needed, hitch up the leaflets, and then we put a separate smaller tube graft for the ascending aorta. And those results I'll show you in a moment. So the reimplantation operation, here's the valve freed up. Then we put those pledgets in the left ventricular outflow tract. You see them there in position. And there's the outside of the aorta with the pledgets in place. Then we use a hay gauze to tie down so we don't constrict the valve, but also make sure we have a good opening. And there you see a repair with a nice symmetrical valve and a figure of eight suture. There's a hitch-up suture. In a lot of these patients, they have Barlow's syndrome, so we do mitral valve repairs at the same time as the reimplantations. There's a completed mitral valve repair. And interestingly, in 54 of our patients who have had combined mitral valve and aortic valve repairs, none of them at this time of study had had a reoperation for either of them. We're now up to 64 patients, and we're in the process of reanalyzing that data. So what happens over time? Well, as I mentioned, the tailoring operation we use in older patients, so their survival is not quite as good. What about repair durability? It's equivalent for all of these groups, better than 90% freedom from reoperation at 9 years. But the bicuspid valves do not have quite as good durability. It's around 90% freedom from reoperation at 10 years with bicuspid valves. If you look by underlying disease, Marfan's, dissection, all very similar, but slightly lower with bicuspid valves. One comment I'll make is that we tried to do remodeling operations for Marfan patients, and that really did not work out well long term. So that's why we do a reimplantation operation for all our patients with connective tissue disorders. Here's a study we did on our connective tissue disorder patients, 178 patients. We're now reanalyzing our data. We've got now 214 connective tissue disorder patients. This is the breakdown in that earlier study, and probably about the same for the current group of patients. And there were no deaths in that series, and in fact, with the 214 patients, we've had no deaths with reimplantation operations in connective tissue disorders, which is quite important since these patients have very fragile tissues. What about effectiveness? Well, survival is 94% at 8 years in the earlier study, and we'll update that. And freedom from reoperation was 92%. The most recent data looks like it's going to be very similar to the non-Marfan connective tissue disorder patients. In other words, durability, despite our concerns, looks like it's going to be equivalent to a non-connective tissue disorder patient. As I mentioned, we've updated this now for 214 patients. Word about Loeys-Dietz. So we have a series from a few years ago, 53 patients, and about half of those patients had valve-preserving operations without any deaths. And in those patients, the long-term durability has also been excellent. And we seem to have avoided the risk of dissection. And so we use 4.2 centimeters. Should we wait till 4.5 or 5? At this stage, we really don't have the data to inform any decisions around that. What about the various types of repairs? And so here's just an illustration, as I've talked about, of the different types of repairs. We started, this is a study from a few years ago, 1,900 repairs. As I mentioned, now we're up to 4,680. And a contemporary series there, we used a lot of different repair techniques. And in the data for the contemporary series, the freedom from reoperation, this is all comers, was 90% at 10 years freedom from reoperation. And if you compare it to the older series, we've become better at doing repairs in these patients. A couple of points: the figure of 8 suture seems to make a difference and reduces the risk of reoperation. And also bracing the aortic root, particularly with reimplantations, also results in a better outcome over time. And as far as survival, it's very similar to age and sex-matched population in the United States. What about root procedures for various types? We had a series of 957 we looked at a few years ago, using various types of operations, the valve sparings, the biological composites, mechanical composites, and homografts or allografts, but equally divided. Interesting, survival was excellent with the Bentalls and obviously valve preservings. The Bentall biologics weren't quite as good. And if you look at mean gradients over time, the valve preservings had the lowest gradients over time. There were 70 reoperations for various reasons in this population. In the foreign material patients, endocarditis was a big factor. Freedom from reoperation at 15 years was 80% freedom from reoperation, so really good results over 15 years. But interesting, the composite mechanical valves had the lowest risk of reoperations over time. Looking at this, the homografts, allografts had a high rate of failure over time. What about comparison of reimplantation versus Bentalls and trileaflet valves? So we looked at our series. We had a mortality rate of 0.16 for Bentalls, reimplantation 0.22 at that time. And the results were very good, depending on the post-operative regurgitation after this procedure. And there was no difference in durability by the size of the aorta at the original operation. When you looked at the severity of post-operative regurgitation by ratio, also no effect on that. But if you looked over time, the patients who had Bentalls had higher gradients over time compared to reimplantations, and left ventricular mass regression was better with the reimplantations. The risk of reoperation was equivalent between the two over time, and survival was excellent in this group of patients at about 97% survival at 10 years. And no difference in survival between Bentalls and reimplantations. At least in that series, that looked good. What about reimplantation in patients with bicuspid valves? Patients with bicuspid valves and reimplantations don't do quite as well as the trileaflet valves, and they have slightly higher gradients over time. And although this is statistically not significant, the difference, we are somewhat concerned that the reimplantation patients may not have as good result over long term if they have bicuspid valves, although the survival is still excellent. Do these procedures prevent aortic dissection? So we looked at 664 of our patients who had valve sparing operations, and the risk of later dissection was 1.4% over time. So from that point of view, I think it is showing the benefits of surgery. When we looked at surgical versus medical treatment of these patients who dissected, it was equivalent. So this was dissection of the descending aortas, the most common dissection we see over time. And it's particularly in patients with connective tissue disorders that there is a risk. So of those 9 patients, there were more patients with connective tissue disorders, which I suppose is not too surprising. Looking at mechanical valves, is there a place for NOACs? That remains to be answered. As part of full disclosure, I'm not reimbursed for it, but I'm one of the co-PIs, national PIs for looking at the Onyx valve, and at 3 months switching patients to what we call a PROAC 10A study, switching patients to Eliquis 3 months after surgery versus Coumadin, and that will take us a few years to get those results, but that still is a possibility. Thank you very much for watching and being engaged in this meeting. We've been number one for 25 years. Now I guess it's 1.5 years ago, and we celebrated 26 years of being number one, quite a marathon last year, and we thank you for your support and being part of this meeting.